Good evening, doctors. It's a great pleasure to invite you and welcome you in our symposium led by Boehringer Ingelheim. In our symposium tonight, we will be addressing the latest clinical advances in the management of heart failure with SGLT2 inhibitors, mainly shedding the light on the latest data on empagliflozin across the broad spectrum of ejection fraction. And we are very lucky tonight to have Professor Hussein Heshmat with us to be leading this symposium. Dr. Hussein is a professor of cardiology in Cairo University, Egypt, and the head of the cardiology department in Fujairah Hospital, UAE. Without any further ado, Dr. Hussein, the floor is yours.
Thank you, Serena. And it's difficult to speak after Dr. Anker. Maybe a few things to add. So we'll be discussing what's new in heart failure from the pharma side. New guidelines have been just released, and now ejection fraction still counts. We still have a reduced ejection fraction of less than or equal 40, from 41 to 49, mildly reduced instead of mid-range. More than or equal 50 is heart failure with preserved ejection fraction. And maybe in the future, we have heart failure with a normal ejection fraction, which may be above 60, we don't know. New in the guidelines, now the 4 medications are on equal stand. ACE inhibitors, class 1A, ARNI, class 1B, beta blockers, MRA, and SGLT2 are all class 1A. And now the aim is to get all 4 therapies as quick as possible and then to up-titrate later on. The class 1A recommendation of the SGLT2, of course, came after the DAPA-HF and the EMPEROR reduced. So we'll go quickly through the EMPEROR reduced. It looked at patients with congestive heart failure, ejection fraction less than 40, with elevated pro-BNP, regardless of the diabetic status. And they randomized them to empagliflozin, 10 milligrams a day, a single dose, a flat dose, versus placebo. And you can see the significant reduction in the composite endpoint of death or heart failure hospitalizations, with a number needed to treat of less than 20, which is another breakthrough in heart failure with reduced ejection fraction. And of course, the question of diabetes is now belongs to the past. Diabetic or non-diabetic, there's no difference. And the effect was more or less consistent among the different groups. And the other thing that we learned is that the background therapy does not affect the efficacy of the drug. So whether the patient was on background of MRA or not, whether there was background of ARNI or not, the benefit was still there. So these molecules are independent. They provide their effect regardless of any background therapy. Not only protecting the heart, the slope of decline in ejection fraction is flat, more flat compared to placebo, and the endpoints, the renal impairment progressing to end-stage renal disease, or more than 40% increase worsening of eGFR, was significantly better with empagliflozin. So now we had another agent to be added to the armamentarium of heart failure with reduced ejection fraction, but we didn't know would it work in preserved ejection fraction or not, because all cardiologists know that heart failure with preserved ejection fraction was something that's hard to reach. Over the last 20 years, almost no agent were able to convince us unequivocally that they can do something useful and tangible in heart failure with preserved ejection fraction. So in our region, how does HFpEF look like? This is the distribution of ejection fraction in patients in the Gulf Care, which was a registry of acute heart failure in the Gulf region. And if we take 40% as the cutoff, then almost 40% of patients in our region have heart failure with preserved ejection fraction, or some mid-range. If we take 50 as the cutoff, then approximately 1/3 or 1/4 of our patients in the region would have heart failure with preserved ejection fraction. And we know from the same study, this is recently published, that the mortality rate in HFpEF is more or less the same as the HFrEF The rehospitalization rates are the same. So it carries the same bad prognosis, and we don't have good therapies. Some of the phenotypes are different between HFpEF and HFrEF, again, in our region. The prevalence of pulmonary hypertension, the levels of pulmonary pressure are much higher, are significantly higher in the HFpEF compared to the HFrEF. So what did we have? What tools did we have in our hands? Close to very limited tools. We know that from the charm preserved that the benefit almost doesn't exist. In ACE inhibitors, we had limited data, mostly from hypertension trials. They were mostly negative. In beta blockers, we had contradictory results from observational and randomized trials. The TopCat study, the final conclusion was negative, but in some geographic regions, there was benefit. So you don't know how to utilize this fact. Nitrates actually were harmful in the majority of situations. Sildenafil failed to reduce the pulmonary artery pressure and failed to improve the exercise tolerance. And the only agent that came close and seemed to be heading in the right direction was ARNI. That's why the FDA approved it as a general indication in heart failure based on the mixed results, based on combining the results of the Paragon and the Paradigm and the others. Although in Parallax, the results were mixed, and the final conclusion of the Paragon was negative, except in some subgroups, which raises the question again, should we believe the subgroup analysis or should we ignore the subgroups? They are just hypothesis generating. And HFpEF is more complex than HFrEF, and you can think of multiple phenotypes. You can think of one type of HFrEF patients, the elderly patients who are frail or anemic, high prevalence of atrial fibrillation, and mostly female gender. That's one side, that's one phenotype. And there's another phenotype which is dominated by obesity, diabetes, sleep apnea, and chronic kidney disease. And that's another phenotype. And of course, hypertension, coronary disease, pulmonary hypertension are looming on both sides. So you can think of 5 or 6 different phenotypes of heart failure with preserved ejection fraction, which makes us think, is it one disease that we are, or it's a mix of diseases and syndromes that we are lumping together because the patient has dyspnea and volume overload. So the empagliflozin showed a marvelous success in diabetes in the EMPERIG outcome, and showed a great success in the EMPEROR reduced in heart failure with reduced ejection fraction. So why not try it in heart failure with preserved ejection fraction? And I will not repeat, of course, what Dr. Anker said. Patients were randomized, 6,000 patients were randomized to IMPA or placebo with the endpoint of death or heart failure hospitalization. And as you can see, the mean ejection fraction was 54, which tells you that this trial was looking exactly at the kind of patients that we didn't have good treatment for. 2/3 of the patients had an ejection fraction 50% or more, and 1/3 had an ejection fraction of 60 or more. The background therapy was highly up to the standard, because we know these patients are usually without an effective treatment, so many of them were on MRAs based on the TopCat. Most of them were on RAS blockers, but less than 2% were on ARNIs. Of course, a big proportion were on beta blockers. These are mostly hypertensive patients with chronic kidney disease and atrial fibrillation, so they were getting the standard therapy for these situations. Half of the patients were diabetic, as you expect in the heart failure population. And of course, we got a significant reduction, which is the first time in the history of medicine that we achieved this result in patients with heart failure and preserved ejection fraction. 21% relative risk reduction. And as you can see, the results are consistent across the subgroups, regardless of the gender, regardless of the age, and regardless of the EGFR, but regardless of diabetes, of course. And we can see that the benefit was maximum in those patients with less than 50. The benefit was still there and robust with ejection fraction up to 60. As we cross the ejection fraction of 60, then we tend to see some flattening of the effect. We don't see the marvelous effect that we saw less than 50 and from 50 to 60. And the background therapy didn't make a difference. Atrial fibrillation also didn't make a difference. Recurrent heart failure hospitalizations was marvelously reduced, 27%. There was also a significant protection, a renal protection. The slope of decline of ejection fraction was more in favor of IMPA. It was less than what we saw in the reduced trial, and we can discuss that, but it was still there. So the pre-specified primary endpoints were all positive. Other exploratory endpoints were not all positive. Of course, heart failure hospitalization was marvelous. Cardiovascular death, we saw a trend. It was numerically less, but it was not statistically significant. And trying to understand the mechanism, what happened at the laboratory level, we see an erythropoietin effect with a significant increase in hemoglobin. Of course, we know the weight effect of SGLT2 inhibitors. They had some mild reduction in blood pressure and some reduction in pro-BNP. The side effect profile was more or less the same. There was some slight increase in hypotension, and we know that. The hypoglycemia was not different. Ketoacidosis was not different. So what does the study add? It's for the first time comparing to ARBs, to perindopril, to irbesartan, to spironolactone, and even to sacubitril valsartan. We saw a significant, robust reduction in death and hospitalization with a significant p-value. So, because what does this study add to our practice? It's the first time that we have a drug that we can offer to patients with heart failure and preserved ejection fraction, not only for reducing hospitalization or death, but also for protecting the kidney. Across the board of heart failure, this is the only agent now that can work on heart failure with reduced ejection fraction, preserved ejection fraction, and improve the renal outcomes. So trying to think why empagliflozin succeeded while the others couldn't. It could be that empagliflozin could act on more than one pathophysiologic phenomenon in heart failure with preserved ejection fraction. We know that it has some anti-diabetic effect. We know that it acts on weight reduction. It has mild blood pressure lowering effect. We know from the IMPA-REG outcome that IMPA is able to reduce the 3-point MACE and the total mortality. We know its beneficial effect in chronic kidney disease. We know also from mechanistic studies that IMPA is able to reduce the pulmonary arterial pressure in patients with heart failure in general. And we've seen its effect on improving the low hemoglobin in these patients. So maybe the combination of all these pathophysiologic mechanisms explain why IMPA succeeded while the others didn't. And this is very recent news, came yesterday from the FDA that it granted IMPA a designation of breakthrough therapy in heart failure with preserved ejection fraction. And up to now, it's the only agent that got this designation. So it's honestly, it's something to celebrate. This weird molecule, I tend to call it a weird molecule because it's the only molecule, it's not the only molecule that works in diabetes, but it also works in heart failure. And it's the only agent now that we know that unequivocally benefits patients with HFpEF in death, hospitalization, and improving the renal outcomes. Thank you so much, and ready for some questions.
Thank you very much. Excellent. Thank you very much, Dr. Hussein. You know, today was all about SGLT2. All good thing. Anyone got questions, comments to Dr. Hussein about IMPA? So it's a BI symposium. You want to have your comment on this? So, Dr. Hussein, IMPA in heart failure, we should be 10 milligram or 25 milligram?
10. The only tested dose was 10. And this is one of the advantages because you don't need to titrate.
Yeah, so if I have a diabetic patient, I want to control is diabetic, and he's already on 25, then developed heart failure, should I go to 10?
Oh, honestly, I don't know the answer of this question. It was not tested in the heart failure trials. And keep in mind that the hemoglobin A1C extra reduction that we get with the 25 compared to 10 is not superb. So if it is only for the sake of diabetes control, not really.
So, and then the ejection fraction, when you say preserved, up to what ejection fraction we are happy with IMPA and the outcome?
Well, if you look at the curves, there was still some benefit up to an injection fraction of 60, but it was not statistically significant. So could this be due to subgroup analysis, which are underpowered, or to the fact that heart failure with an ejection fraction more than 60 is a completely different phenotype? It's predominantly females, predominantly atrial fibrillation. The pro-BNP is not much elevated compared to the other phenotypes. So it could be another disease that we don't understand yet. Could be some hidden amyloidosis, hidden restrictive cardiomyopathy. This could be the explanation.
So Dr. Rosano, the HFpEF is gender or age related, or what is it?
I think that we get more women in preserved, and and also an increased elderly population. So it's there is this combination of elderly women that are often are diabetic, hypertensive, and so this is a phenotype. And as suggested, probably different phenotypes have respond well. But there's the nice picture that Milton Parker published in his paper on the consistency of the effect of empagliflozin over the ejection fraction is impressive, because up to 65%, yes, there's a benefit. So of course, above 65% is different, but probably women, smaller heart, different compliance. But that is what is nice. We still have got work to do, no? Despite this drug are terribly effective.
Thank you, Dr. Hussein. Thank you very